Have you ever thought about what would happen if one of your body's most basic systems, the one that handles rest and digest, just went into complete overdrive and wouldn't shut off? It can happen in an instant. First, you're just sweating. Profuse, uncontrollable sweating. You're completely drenched. And then your heart, it just plummets. That steady, normal rhythm is gone, replaced by a dangerously slow beat. On top of all that, a massive wave of nausea hits you. This isn't just one thing going wrong. It's a full body system failure. So what on earth is going on here? In this explainer, we're going to decode exactly that crisis. What happens when your body's rest and digest system gets stuck in the on position? To really get a handle on this crisis, we've got to meet the system in charge. This is the cholinergic system, and it's the master controller of your parasympathetic functions, what we all call rest and digest.
And the star of this whole show is a neurotransmitter called acetylcholine, or just ACH for short. You can think of ACH as the little messenger molecule that tells all your organs, hey, time to chill out, conserve some energy, and let's get that digestion going. Now, acetylcholine doesn't just go anywhere. It has two main types of docking stations, or receptors. On one side, you've got muscarinic receptors. These guys are all over your major organs, your heart, your lungs, your gut. On the other side, you've got nicotinic receptors. These are mainly on your skeletal muscles and in these little nerve hubs. But for our story today, for this crisis scenario, we are laser focused on those muscarinic receptors. And this diagram shows you exactly why. In that whole rest and digest system, the final command, the message from the nerve telling the organ what to do, it happens right here. ACH binds to a muscarinic receptor. That is the switch. It's what tells your heart to slow down or your glands to make saliva. It is the crucial final step. Okay, so now we know our main player, ACH, and its main target, the muscarinic receptors. So let's circle back to that crisis. What happens when there's just way too much acetylcholine and it's hammering all of those receptors at once? Well, clinicians have a fantastic mnemonic to remember all the signs of this cholinergic overload. It's DUMBBELLS. Let's walk through it. The D is for diarrhea, as the gut goes into hyperdrive. U is for urination. M is for meiosis, which is when the pupils constrict down to tiny pinpoints. The first B is a double whammy. Bronchospasm, your airways tighten up, and bradycardia, that slow heart rate. The second B is for emesis, which is just a fancy word for vomiting. E is for lacrimation or tearing. L is for lethargy. And finally, the S brings us right back to the start, salivation and that crazy sweating. You can see it's a complete system meltdown.
Now, here's where things get really interesting. Sometimes we actually want to boost this system on purpose with pharmacology. So how do we do that carefully without accidentally triggering a crisis? Well, let's talk about the drugs. There are two main strategies here. On one side, you have direct-acting agonists. These are like perfect impersonators. They mimic acetylcholine and activate the receptor all by themselves. But on the other side, you have the indirect-acting agonists. These are a little more clever. They don't touch the receptor. Instead, they block the cleanup crew. That's the enzyme that normally gets rid of ACH. So let's look at those mimics first. Drugs like bethanacol and pilocarpine work by binding straight to the muscarinic receptors and just turning them on. And clinically, this is incredibly useful when you need a very targeted effect. We use bethanacol to stimulate the bladder, helping with urinary retention. And we use pilocarpine to constrict the pupil, which helps relieve pressure in glaucoma. So to understand those indirect drugs, you first have to see how ACH normally works. It's a pretty simple cycle. It gets made, it gets stored, then it gets released, it crosses the gap, binds to the receptor, and delivers its signal. And then, this is the most important part, it's immediately destroyed by an enzyme called acetylcholinesterase. That's our cleanup crew. And that step is what keeps the signal from just going on forever. This is what the indirect agonists target. They put a hard stop on step 5. By blocking that acetylcholinesterase enzyme, they stop ACH from being broken down. So what happens? The acetylcholine just hangs around in the synapse way longer, stimulating the receptors over and over and over again. It amplifies the effect. This is actually the very mechanism we use for conditions like myasthenia gravis, where you need to boost a weak signal between a nerve and a muscle. So, we know how to turn the system up, but what about that emergency? When the volume is cranked to the max by something like organophosphate pesticides or even a nerve agent, how do you shut it all down? The answer is a class of drugs called anticholinergics, and the classic example is atropine. It works by being a shield. It literally goes in, sits on top of the muscarinic receptors, and physically blocks acetylcholine from binding. If ACH can't bind, it can't send its message, and the rest and digest overload gets stopped dead in its tracks. And this is a perfect visual of that push and pull dynamic. On the left, a cholinergic agonist, one of our boosters, like pilocarpine, makes the pupil constrict. That's meiosis. On the right, an anticholinergic, our antidote, like atropine, does the exact opposite. It makes the pupil dilate. That's mydriasis. It's a perfect picture of an agonist versus an antagonist at work. And all of this information comes together in a real-world clinical playbook like this one. This flowchart guides a clinician from recognizing those dumbbells signs of a cholinergic crisis all the way to giving the right dose of the antidote, atropine. It connects everything we've just talked about, from the symptoms to the mechanism to the treatment. So let's end this with a quick challenge to pull it all together. A farmer comes in with pinpoint pupils, a slow heart rate, and is salivating like crazy after working with pesticides. Based on what we've just covered, what class of drug is the antidote? And more importantly, how exactly does it work to save his life?